everyone. We are going to start our next session. Sorry, we don't have chairpersons for the discussion. We have just the presenters. So I shall be presenting a case of bone in the eye, a rare case of choroidal osteoma involving the macula. Choroidal osteoma is a rare benign ossifying tumor of the choroid, first described by Gass in 1978. It predominantly occurs in healthy young females in second or third decade. It is located in the juxtapapillary or peripapillary area, mostly unilateral with unknown etiology. Patients are usually asymptomatic. They may have mild to severe blurring of the vision, metamorphopsia or visual field defect corresponding to the location of the tumor. Presenting a case of young 18 years female, she complained of blurred vision in the left eye for 2 months. She had no history of systemic illness or trauma. Her best corrected vision was 20/20 in both the eyes. Anterior segment exam was normal. Right eye fundus was normal. This is the fundus photograph of the left eye. We can see a mass involving the posterior pole, yellowish orange in color, and the retinal blood vessels running over it. It means the mass is subretinal and it has got well-defined margins. The lesion was hyper on autofluorescence. On OCT, the retinal layers, they were raised somewhat, means the lesion is subretinal. This is the angio. In FFA, in early phases, there was patchy hyperfluorescent lesions with diffuse staining in the late phases. B-scan was diagnostic in this case. There was hyperechoic area with the anechoic area beneath it, and the size of the lesion was 10.69 millimeter, and it gave the appearance of pseudo-optic nerve. So we made a diagnosis of choroidal osteoma. So these things we kept in the differential diagnosis could be amelanotic choroidal melanoma, choroidal nevus, metastasis, hemangioma, disciform macular degeneration, posterior scleritis, idiopathic sclerochoroidal calcification or choroidal cartilage. These are the few features of choroidal masses. So B-scan is very diagnostic in choroidal osteoma. Patients, they are usually asymptomatic, but choroidal neovascular membrane can develop, and multimodal imaging always helps to differentiate from other choroidal masses. So to conclude, choroidal osteoma is a rare benign ossifying tumor, usually juxta or peripapillary in location. Macular involvement is rare, as in this case, since the macula was involved but the vision was 6/6. And B-scan is very diagnostic. Early diagnosis of choroidal osteoma helps to keep the patient under close follow-up for the detection and treatment of complications like choroidal neovascular membrane. Thank you. Now we can have our next speaker.
I am Dr. Kritika Jain. I will be presenting this case of gyrotrophy with macular edema on behalf of Dr. Manisha Nada. Gyrotrophy is a rare progressive autosomal recessive metabolic disorder primarily affecting the retina, leading to vision loss over time. It is characterized by sharply demarcated circular or scalloped areas of chorioretinal atrophy starting in the mid-peripheral retina and gradually extending centrally. Progressive loss of vision, often beginning with night blindness in childhood or adolescence. It is caused by a deficiency of the mitochondrial enzyme ornithine aminotransferase due to mutations in the OAT gene. So in this cycle, we can see that the mutation in the OAT gene can result in an inefficient metabolism of the ornithine, resulting in hyperornithinemia. This hyperornithinemia can lead to degeneration of the RPE, choriocapillaries atrophy, progressive death of photoreceptor cells, mitochondrial dysfunction and oxidative stress, and these changes begin in the mid-periphery and then advance towards the posterior pole. Now moving on with the case report, a 24-year-old male presents with diminution of vision in both the eyes, difficulty seeing at night, and along with he also had complaints of hearing loss. There was no significant past medical history, but a family history was positive in the sense that his elder brother also experienced the same complaints. The ocular examination revealed vision of 636 in both the eyes, rest was not significant. On the fundus examination, we can see in the both the eyes there are peripheral lesions. In the left eye they are more prominent rather than the right eye. And on the OCT we can see a cystoid macular edema which is more in the right eye. And on the blood investigation there was raised plasma ornithine levels, reduced plasma arginine levels, and slightly low vitamin B6 levels, which indicate that that tablet pyridoxine trial should be done. And on pure tone audiometry there was bilateral sensorineural hearing loss. While managing the patient, he was started on tablet acetazolamide 250 milligrams BD along with eye drop dorzolamide 2% BD. Due to the limited response and not significant results, he was given an intravenous triamcinolone injection, and dietary modifications were advised, that arginine restricted diet, nuts, seeds, legumes, pulses, etc. to be avoided, whereas white rice, white bread, pasta, fruits and vegetables are preferred, along with vitamin B6 supplementation. And the serial plasma ornithine levels were monitored, and along with biannual ophthalmological examinations with OCTs and HFA, and genetic counseling was advised. So to conclude, diabetic atrophy typically presents in the first 2 decades of life and progressively leads to severe visual impairment. The classic fundus appearance is of a scalloped geographical area of chororetinal atrophy are diagnostic. Hyperornithinemia is central and pathogenesis and is caused by OAT deficiency. Treatment aims to reduce ornithine levels through arginine restriction and vitamin B6 diet, which may help in pyridoxine responsive cases. Thank you. I'll be presenting this case of familial exudative vitreoretinopathy, early detection and management. FEVR defines a group of inherited retinal diseases characterized by abnormal retinal angiogenesis leading to incomplete vascularization of the peripheral retina with subsequent retinal ischemia. It shows genetic heterogeneity, variable penetrance and asymmetric presentation. Disease asymmetry is typical and variable phenotypic expressivity of retinal abnormalities may result in a unilateral case. It can be inherited as autosomal dominant, which is the most common form, or autosomal recessive or X-linked recessive disease. The pathogenesis involved that there is an abnormal angiogenesis in the periphery resulting in ischemia leading to hypoxia, stimulating the new vascular growth, which later results in vitreoretinal traction, subretinal exudation, retinal folds, hemorrhages. And on the left we can see these are various genes that are involved. A 6-year-old girl presented to the OPD of RIO PJMS Rohtak with complaints of diminution of vision in the right eye. The birth history, she was born at full term via spontaneous vaginal delivery to a 31-year-old woman with an uncomplicated pregnancy, and no oxygen had been administered during the neonatal period, no history of trauma, family history not significant, systemic examination within normal limits. The right eye had a vision of 660 and the rest anterior segment examination was normal, whereas the posterior segment examination, the right eye showed a peripheral avascular zone along with lipid exudation in the macular region. And the OCT of the right eye also shows that there is an abnormal foveal contour along with subretinal exudation. And the FFA shows there is avascular retina in certain areas, and the dye is leaking surrounding the neovascular fronts. The patient was given injection ranibizumab along with laser photocoagulation done for the avascular area and was followed up every 4 to 6 months for the first 4 to 6 weeks for the first 3 to 6 months, followed by 3 monthly for the next year. Now visual rehabilitation plays an important role. It involves early detection and amblyopia management, patch therapy, penalization in unilateral cases with amblyopia, timely refractive correction with glasses or contact lenses, low vision aids involving magnifiers, telescopic advices, electronic low vision aids, large print material and accessibility tools, educational and psychosocial support, special education support for children with low vision, counseling for the parents and family regarding chronic nature of FEVR, genetic counseling for family planning. Now DDs involve ROP, but FEVR is usually a disease in babies who are born at term. They are of healthy weight category. Norris disease, there is, unlike FEVR, Norris has microphthalmia, corneal opacities, developmental delays and deafness. And in Coats disease, it is a unilateral condition more frequently seen in boys. Unlike FEVR, neovascularization and traction membranes are not seen. And in incontinentia pigmenti, there are characteristic skin lesions at birth and neurological symptoms as well. To conclude, it is an inherited vitreoretinal disease characterized by abnormal retinal vascular development leading to varying degree of ischemia. The presentation may mimic the presentation of other pediatric and adult vitreoretinal disorders, and the wide variability in patient characteristics implies that the diagnosis of FEVR cannot be easily excluded based on birth weight, gestational age of presentation, family history, or evident laterality of disease. Accurate diagnosis of FEVR is important because the unpredictable timeline of the progression warrants lifelong monitoring. Thank you.
everyone. My topic is from trauma to herniation, sequential OCT documentation of macular hole. Coming to its introduction, it is a full thickness defect in the foveal region of the retina that develops after blunt or penetrating ocular trauma. They are caused by sudden mechanical forces on the globe, and patient will present with decreased central vision, central scotoma, and metamorphopsia. Usually these patients are observed and closely followed for spontaneous closure is done. If hole persists and with significant vision loss, then we can go for surgical treatment like pars plana vitrectomy with ILM peeling and gas tamponade. This presentation will highlight a case of an 11-year-old male patient who was diagnosed with traumatic macular hole, its sequential OCT, and its fate of the macular hole. So the boy presented to the hospital with diminution of vision following a cracker injury 1 week before in right eye. On examining the right eye, best corrected visual acuity was 20 by 120. And anterior segment findings were within a normal limit. Coming to the posterior segment of the right eye, we could see media being relatively clear, blurred disc margins are present, and vessels are arising from the center being mildly dilated. Coming to the macula posterior pole, we could see Berlin's edema, and incomplete macular star appearance is present with small macular hole is there, which can be confirmed with OCT macula, and also PRH is present superotemporally. So OCT macula was done, and we could see hyperreflective echos at the VR interface, which is suggestive of dispersed VH, and a full thickness macular hole is present with subretinal fluid. On OCT of the disc, we could see elevated disc margins, which is suggestive of disc edema. So this patient was observed and closely follow-up was done, and patient was called on second week. On second week of presentation, the OCT macula revealed hyperreflective spots were still present, suggestive of an dispersed VH. There was retinal thickening with an hyperreflective membrane present over, which is the ERM. So again, the patient was called at 1 month, and OCT revealed reduced hyperreflective spots, marked retinal thickening with inner retinal layer protrusion over the ERM, which is suggestive of the foveal herniation. At second month from the presentation, patient was again called, and the OCT revealed worsening of that foveal herniation. At third month, we could see worsening on the OCT, and the fundus photos revealed there was glial proliferation tissue around the optic disc margin, suggestive of the resolving disc edema, and in the vessels are being mildly dilated and tortuous. In the posterior pole, we could appreciate the glial tissue proliferation and the macular content protruding out. Inferiorly, we could also see the exudation present. So, as there was no any significant improvement in the visual acuity over the 3 months, and we could see the worsening of the OCT, VR intervention was planned, like pars plana vitrectomy with ERM and ILM peeling with gas tamponade was planned for the patient. But as patient's parents were not willing for the surgery, thus the patient lost for the follow-up. So, as we know, traumatic macular hole is usually rare in children, but it is vision threatening, often follows blunt trauma, and usually present with central vision loss, scotoma, metamorphopsia. Children show higher spontaneous closure rate, that is within 3 to 6 months, due to strong vitreoretinal adhesion and better healing potential. Hence, for this case also observation with OCT monitoring was done. But as there was no any significant visual improvement and worsening of OCT changes would be seen, so surgery was planned for this patient. So the conclusion of my presentation is macular hole and ERM in young individual is uncommon occurrence, with trauma being prevalent case in this age group. Close monitoring is crucial for the spontaneous hole closure and ERM, as ERM tends to progress rapidly in younger patients compared to adults. Thus, early diagnosis, close monitoring, and timely intervention are crucial for achieving optimal visual outcomes. Thank you.
Good afternoon everyone. Today I will be discussing a unusual presentation. A 14-year-old presented with bilateral disc edema with unilateral retinal detachment. This case there was a weak syndrome versus IIH, a diagnostic dilemma. Now, as we all know, VKH is an idiopathic T-cell mediated autoimmune inflammatory disease involving multiple systems, most commonly nervous, ocular, auditory and integumentary system. It is prone to be misdiagnosed and treated as other common diseases like idiopathic intracranial hypertension, especially in its prodromal stage in view of headache and visual symptoms, which may be sometime lead to delay in early diagnosis and vision-threatening complications. A 14-year-old female presented to our ophthalmologist complaining of sudden diminution of vision in both eyes that had been occurring for the previous 5 days. It was associated with diffuse headache and nausea. There was no history of diplopia, hearing loss, tinnitus, alopecia, vitiligo or any previous ocular surgery or any trauma. On ocular examination, right eye visual acuity was hand movement close to face with accurate perception of light in all quadrants. Anterior segment, there was no cells, no flare or no chorotic precipitates. Pupillary reaction was RAPD grade 2. Extraocular movements were restricted temporally. On fundus examination, there was masked disc edema with elevated disc margin with exudative retinal detachment which was surrounding the disc with tortuous blood vessels and few hemorrhages in all quadrants. On left eye examination, visual acuity was found to be finger counting close to face with accurate PL in all directions. Similarly, there was no cells and anterior segment was quiet. Pupillary reaction was sluggish. Extraocular movement was within normal limits, and on fundus examination, there was marked disc edema with elevated disc margin, mild tortuous blood vessels, and normal maculofoveal reflex. On further investigation, complete severe blood count and other systemic evaluation was done to rule out any infectious as well as autoimmune etiology. OCT was done and right eye OCT was there was found to be subretinal fluid, whereas on left side OCT there was mild edema present. B scan was suggestive of thickened retinocoroidal complex. MRI was suggestive of raised intracranial pressure. There was an optic nerve sheath distension and flattening of the globe in absence of any mass lesion, which was primarily suggestive of idiopathic intracranial hypertension. On lumbar puncture, there was mildly elevated opening pressure with mild pleocytosis. MR venography was done to rule out sinus vein thrombosis, and there was no abnormality noted. This is the picture of the OCT. There were due to the lack of signs of anterior uveitis and other clinical findings, this coming to the diagnosis was troublesome. But as there was a presence of unilateral exudative retinal detachment, which is an atypical feature for IIH, hence a diagnosis of incomplete VKH syndrome was made in the presence of IIH-like imagining. Patient was further subjected to IV MPS 1 gram per day for 5 consecutive days, following which the visual acuity improved to 4 emitter finger count in right eye and 6 MFC in left eye. Unfortunately, the patient was further lost to follow-up. So to conclude, VKH syndrome is an autoimmune disease with myriads of signs and symptoms which can be misdiagnosed with other clinical entities, like in our case as idiopathic intracranial hypertension. A thorough registry with both systemic and ocular examination with relevant investigations will lead us to a conclusive diagnosis, thereby helping clinicians to start with prompt treatment and prevent vision-threatening complications. Thank you.
Retinitis pigmentosa, it is an inherited retinal disorder with progressive degeneration of rods and cone photoreceptors. Occurrence is 1 in 5,000 and it has more than 80 genes implicated. The symptoms: patient presents with nyctalopia and peripheral loss of vision. The classic fundus picture is of bone spicule pigmentation, vessel attenuations and waxy pale optic disc. It can be associated with posterior subcapsular cataract, high myopia, macular edema, keratoconus, optic disc drusen and syndromic forms. Here I am showing a case of atypical variant of retinitis pigmentosa. So a 19-year-old female presented with complaints of diminution of vision in both eyes, more in left than right, since last 6 months, which was gradually progressive. No history of any ocular trauma, no difficulty in seeing dim light, no history of delayed milestones or consanguineous marriage history in the parents. So her vision was 6/24 in right eye and left 6/60, which was improving to 6/9 and 6/18. Anterior segment was normal. Coming to the fundus picture, we are able to see in both the eyes, we are able to see cystoid macular edema, some mild vascular attenuation, and extensive RPE degeneration in the whole background. So the fundus autofluorescence shows a ring around the macular, hyperfluorescent ring around the macular region, which demarcates the layer of normal and the degenerated retina. So OCT shows cystoid macular edema and outer retinal layers are disrupted. So coming to the visual field, we can see a complete ring scotoma over the left eye, and right eye has partial diminution, reduced peripheral visual field. So in the full field ERG, we are able to find the first three images are the dark adapted images where we are having no responses, and in the light adapted images we are having minimal response. So this shows that the scotopic vision is like extinguished peaks and photopic has reduced amplitudes. So as coming to this discussion, we are seeing that initially it was clinically difficult to diagnose. With ERG, we are able to diagnose that this is a case of retinitis pigmentosa sin pigmento, a variant of RP where pigmentations are absent. The patient was managed with carbonic anhydrase inhibitors, vitamin A, and visual acuity was corrected. Genetic counseling was given. So retinitis pigmentosa sin pigmento is a variant of RP where typical bone speckle pigmentation is absent. The retina may appear deceptively normal. It may sometimes present with RP atrophy, gray retinal flecks, and disc pallor and vessel attenuations. Only through imaging and ERG we are able to come to the diagnosis, and genetic analysis may support the diagnosis. So the key takeaways are the atypical forms will delay the recognition of the diagnosis. The phenotype variants need to be carefully assessed for accurate identification, and multimodal diagnostic is needed for these cases, and early diagnosis can help in timely genetic counseling and adaptation of the patient. Thank you.